disorders. I will request Dr. Swati to talk about COVID and neuro-ophthalmology, which has now become one of the most interesting, important topics of discussion over the past 1.5 to 2 years. And we have seen a fair amount of patients of neuro-ophthalmic disorders in association or in patients with COVID. So sometimes we are not very sure how strongly the association is, but of course, you have to always keep in mind. Can the slides be projected? Dr. Swati, please.
Thank you, sir. And now we come to the toast of the season for last 2 years, COVID. So a lot of manifestations, including neuro-ophthalmological manifestations, have been noticed in cases of COVID. And I'll be taking through this presentation. So coronavirus, as we all know, is basically an RNA beta coronavirus and has a very high affinity for AC2 receptor, and through which it acts and gives all kind of manifestation. The other way could be an immune mediated reaction. So what started basically as a respiratory system disease has now turned out to be a multi-system disease, and ophthalmology is not spared. So there are various ophthalmological manifestation of anti-segment in posterior segment, orbital, and of course neuro-ophthalmology, which we will be talking about in this talk. So around 36% of cases of COVID will show some or the other neurological features as shown in the study by a study from Wuhan, China. And neurological features were seen in around 57% of cases in a study from Spain. So neurological disorder with the likelihood are more commonly seen in patients which have the history of in-hospital admission. So pathomechanism, there can be numerous pathomechanism. It can be a primary neurotropism. It can be an immune response due to cytokine storm. It can't be a secondary to a complication due to hypercoagulability state. Can it be a vaccine related, or it's just an association and incidental finding happening in a COVID patient? So we can never be sure of the exact pathomechanism. So there are various neuro-ophthalmological manifestations: headache, vision loss, mainly due to optic neuritis and papilledema, disc edema, eye movement disorders presenting as cranial nerve palsy, nystagmus, myasthenia gravis, and neurological syndromes. Cortical diseases presenting as CVAs and Press syndrome. So pathophysiology basically involves, as I was saying, could be a direct mechanisms of the nerve directly the virus directly invading the nerve, or it could be related to the inflammatory storm that we commonly see in COVID patients, or it may be because of the hypercoagulative rate. So each of these immune mechanisms or each of these pathogenesis have a different manifestation depending on at what phase the patient is. So coming to the individual manifestation, as optic neuritis is reported both in active as well as in recovery phase. It can be because of the increased cytokine storm or an immune mediated reaction. It is more commonly seen in patients of NMO and MOG. What I'm trying to say that patients who have COVID are showing more commonly the presence of NMO-associated antibodies or MOG-associated antibodies, generally seen 4 to 6 weeks, and is usually bilateral in presentation, may or may not recover with steroids. So this is just a case to show that this lady presented with vision loss for 5 days. She has a history of COVID 2 months back, has a history of diabetes for 10 years, and the visual acuity in right eye was very poor. There was right eye RAPD, and this was her fundus picture. You can see the disc edema was there in the left eye. So what appeared as an ischemic optic neuropathy in a first glance was on MRI was shown that both right and the left optic nerve was thickened, edematous, and had bilateral enhancement with a fast and standing suggestive of an inflammation. So what appeared as an ischemic optic neuropathy has turned out to be an inflammatory optic neuritis. So we recently have reported another case of neuroretinitis in association with COVID, where a lady presented with diminution of vision for 10 days and a history of COVID 1 month back. There was no other finding except for disc edema and a macular star. And on investigation, the only finding was raised CRP levels. We gave her steroids and she recovered over a period of time. Papillophlebitis has also been reported in literature, although there is just one case, but the possibility is always there because of the hypercoagulability. There can be a disc edema along with the venous congestion. Papillary edema has now been increasingly reported in cases of COVID patients because of its hypercoagulable state and pro-inflammatory state. Cortical venous thrombosis is commonly seen in, and therefore the MRV becomes mandatory in these cases, and in children it presents as Kawasaki disease syndrome involving multiple systems of the body. Raised inflammatory markers and altered sensorium is also seen in these patients. Posterior reversible encephalopathy syndrome is now commonly being reported in these patients, which is an altered mental state along with the visual impairment and occipital and parietal lobe edema, which has a characteristic MRI finding, and various cases have now been reported. Again, cranial nerve palsies, which can be reported as which are seen as an isolated cranial nerve palsies or part of various syndrome. They can be third nerve involvement has been reported, fourth nerve palsies, sixth nerve palsies have been reported in association with COVID-19, generally within the few days of fever and onset of cough. Even neuro-ophthalmic conditions like INO have been reported. Sixth nerve palsy can also be seen in association with raised ICT. So syndromes like Guillain-Barré syndrome and have also been reported. There have been cases where the MRI have been shown to have the direct cranial nerve inflammation suggesting of direct neurotrophic mechanism of the virus. Progressive bilateral facial palsy have also been reported, and some of these cases have shown the response to immunoglobulin. Movement disorders in form of ocular myasthenia gravis is reported in multiple cases in association with COVID, and the antibodies directed against the SARS coronavirus may also cross-react with the acetylcholine receptors, which may lead to the manifestation of myasthenia gravis kind of a picture. Again, nystagmus may be seen because of cerebellar involvement in association with ataxia and myoclonus. Then it's also other feature could be, it can also be seen in association with INO and vestibular dysfunction. Pupillae disorders, Eddy's pupil has been reported. Then anisocoria has been reported due to presence of third nerve palsy. And in encephalitis also pupillae disorders, slow responding pupil has been reported. Headache is one of the common complaints as more commonly seen in health workers. It's usually pulsatile de novo incidence of headache, which is localized to forehead, temporoparietal and periorbital region, which may be relapsing and resistant to common analgesics. The pathophysiology of headache is either related to the increased cytokine levels or indirect activation of trigeminal nerve due to the virus. Then COVID-19 and stroke, I think, is one of the most common manifestation which we have seen in the last wave, which India had faced in last year. So there was around 7.6-fold increase in odds of stroke along with the COVID virus as compared to the influenza virus, and this kind of stroke was generally large vessel stroke, especially in young. So we have now multiple cases of such kind of patients. The most common mechanism seems to be an increased level of the inflammatory markers in these patients, and it could be post-immune mediated response as well. The COVID vaccinations are not without their complications, and multiple complications even with vaccines have been reported, like acute macular neuroretinopathies have been seen. There have been reports of Bell's palsy, reports of CSR, reports of various vascular occlusion, CRVO, CRAS, all have been reported with the vaccines. So to conclude, there is growing evidence of neuro-ophthalmic manifestation in COVID, either during the disease course or even after the disease has subsided. So, and sometimes it can actually be a presenting features of these patients. So is this association is true, or is it just a coincidental, or just two things are co-presenting at the same time? It's still to be confirmed and needs to be ruled out. However, this differential should be kept in mind, particularly in the current setting of this pandemic. And it's important to rule out COVID with the help of RT-PCR, antibody titers, and coagulation monitor markers to completely diagnose these cases. Thank you.
Thank you, Dr. Swati, for an excellent coverage of COVID-related neuro-ophthalmology.